Okie dokie. I'm going to share my screen. PowerPoint. Fantastic. Okay, so Sam, can you let me know if you can see my the screen, please?
Yeah, it can see it.
Brilliant. Thank you very much. Great. So the topic this evening is Pharmacy First, and hopefully you're all aware that there are some changes coming up next week, actually. So very little time to get this under your belt. We've also combined this with just a bit of feedback that we've had from pharmacies and others within the system for how we could potentially do the service better and maximise income from the service. Quite important for us to make sure that pharmacies are sustainable going forwards. So what we're going to look at the changes to Pharmacy First to start with. Highlight any operational actions that you're going to need to do before next week to make sure that you're compliant and ready to go, and then explore some practical strategies to maximise income from the service based on feedback that we've been given, we've collected from committee members, shared good ideas, that sort of thing. I don't need to go over this with you, hopefully. What is Pharmacy First? Just to clarify that the Pharmacy First bit of this service that we're looking at is the typical Pharmacy First that was started last January, the advanced service. I know some people in the ICB and wider have started to include hypertension case finding service and contraception service under the sort of name Pharmacy First, but we're just looking at the pure Pharmacy First service. So as a reminder, referrals into the service can be for all three parts of the service, which consist of minor illness referrals, clinical pathway referrals, and emergency supply of medicines referrals. And those referrals into the service can come from general practice, NHS 111 or 111 online, and urgent and emergency care settings, and they still have to be electronic. The walk-in part of the service is only clinical pathways, so you cannot do minor illness assessment as a walk-in and claim for it. Under the Pharmacy First service, you also can't do emergency supply of medicines as a walk-in and claim for it under the Pharmacy First service. But what you can do for emergency supply of medicines is tell a person stood in your pharmacy to go on to the NHS 111 online service and log it as an emergency supply, and that's sort of, you're allowed to do that. As a reminder, this service was introduced to help free up pressure on general practice, that we could debate how good they've been at referring into pharmacy, and to give quicker and more convenient access to services for patients, helping them get the right treatment at the right place and in the right time. Building on this sort of foundation, the NHS 10-year plan was released a few months ago, and community pharmacy is mentioned throughout the plan, with its aim to transform community pharmacy to deliver more clinical services and integrate it more into neighbourhood health services with general practices. Key aspects that were highlighted in the NHS plan include managing chronic conditions, specifically obesity and high blood pressure, and that's been highlighted with the obesity pilots that are going to be, well, they're out for tender at the moment, or expression of interest at the moment, and hopefully those will include community pharmacy in a big way going forwards. And things like the IP Pathfinder service, where in Gloucestershire we've got one that's based on hypertension, high blood pressure, that sort of thing. So actually the stated direction of travel for us, we're already working on it. Delivering more vaccinations and screenings. Obviously, NHS England sprung the childhood 2- and 3-year-old flu vaccine on us this year. We'll probably get things like RSV and shingles going forward over the next few years as well. And also integrating pharmacies into the single patient record, looking at these sort of three big shifts: hospital to community, analog to digital, and sickness to prevention. We do have to look carefully at our digital systems. Pharmacy's not been very good at this traditionally, so it's sort of time to look at this going forwards. And the changes to Pharmacy First are sort of aimed to try and help us move in this direction, this more clinical direction. So they've looked at the clinical pathways in the PGDs and tried to identify, you know, what's not working at the moment and how we can encourage more people to do it. The IT system updates to sort of obviously to reflect the clinical pathway and PGD changes, but also to try and streamline the process, get better information back to general practices, that whole analog to digital loop. And They're obviously changing the payment structure for this again. I think NHS England does this to confuse us because it's obviously the second one this year for the payment structure, and it will be changing again next year, but we'll go through that in more detail in a moment. If anyone does have any questions, by the way, just speak up. So we're going to start by looking at the clinical pathways and PGD changes for pharmacy first. And I've got a lovely summary table here, which I've stolen from Day Lewis, which I've emailed to Sam, and she's going to upload onto the Community Pharmacy Gloucestershire website. And that just summarises all the changes, but I'm going to go through them all one at a time just to make sure we sort of understand where the changes are to the clinical pathways and obviously the PGD legal documentation. So first one is sore throat. So most of the criteria are still the same for these services. They've just sort of shifted the gateway points, added new gateway points and a bit more information. So something you'll notice with all of the clinical pathways is that there is now a link to the NICE clinical services somewhere on the page for all of these. So if you save the clinical pathways to your desktop and use an electronic copy when you're doing consultations, then you can hyperlink straight to the NICE clinical guidance, which is very convenient. All of the pathways also have a new gateway point added right at the beginning of the service for anyone that you need to escalate to urgent or emergency care. So for sore throat, for example, so anyone who comes in for suspected sepsis, for example, you can highlight, will hit a gateway point and you can claim for that. With sore throats, it's things that you think it might have epiglottitis, or they've got stridor or something like that. And you need to refer them urgently to A&E or call an ambulance for them, then you can claim. You couldn't do that previously. Within the sore throat service, the gateway point for a fever pain score of 4 or 5 is still the same as it was. The fever pain score linked to fever pain 2 or 3 has actually shifted up a bit. In practical terms, it's still in this pathway, so you know, you could claim for fever pain score 2 or 3, you still can. They've just moved it up a bit to sort of make it more visible and to clarify. So pretty much anything over fever pain score of 2 should be being dealt with by the pharmacist, and you should be claiming for that. There is also a new gateway point in the sore throat service, and this is the gateway point for returning patients, where the pharmacist reassesses and where the patient has been told to go away and come back to you if their symptoms don't improve after a certain length of time or worsen within a certain length of time. So when you're doing your safety netting, you're telling the patient to come back to you. If that patient comes back and you have to reassess them, then they hit a gateway point and you can claim for that patient again. So you can claim twice for patients where you're sending them away and doing a second consultation with them. So that's the changes for sore throat. Hopefully those will actually give us a lot more consultations that we can claim for. In real terms, you know, it's not much change, but it is visibly easier to see what you can claim for now. Acute sinusitis, and this one is a fairly big change. So again, we've got the link to NICE in there and this gateway point, new gateway point for anyone you need to refer to urgent or emergency care. And within sinusitis, the gateway point has now moved. So previously, if you saw someone with acute sinusitis, you had to wait until they had symptoms for more than 10 days in order for them to hit a gateway point and you to take them through the pathway and then claim for them. The gateway point has now moved. So it's moved to before the time period for sinusitis. So actually you think, I've got sinusitis, I've got acute sinusitis, I've got symptoms of facial pain, reduction in sense of smell, that sort of thing. Yep, you've got acute sinusitis. Now you hit the gateway point before you do have you had it for less than 10 days? Or I've only had it for 2 days. Oh, bugger off and come back to me when you've had it a bit longer. So that sort of thing. So you hit the gateway point the moment it's acute sinusitis, not acute sinusitis for more than 10 days. Again, this will hopefully give us a lot more patients who hit the gateway point, who we can claim for and who we can treat with self-care, like an OTC consultation.
You've muted yourself, Becky, I think.
Okay, sorry. Thank you for that. So shingles. So just again, the link to NICE clinical knowledge summary and the gateway point for urgent or emergency care referral. they're new. And again, the gateway point has moved in shingles as well. So a lot of the changes to the clinical pathways are just moving a gateway point. What this means in real terms for shingles is that when you're assessing the symptoms of patients who present in with shingles, if you think they have shingles, you do a quick, any red flags, refer them, and then you go into the more detailed, what's the symptom progression, any other symptoms, what's the distribution of the rash, etc., things like that. And if you get to that point and then decide shingles is less likely, actually, this is a, this isn't a typical shingles rash. Previously, you wouldn't have been able to claim that, and now you can. So it's signs and symptoms of shingles, but before you've done your more detailed history taking, clinical symptoms, and more questions there. So again, a lot more patients that we should be able to claim for in the shingles pathway. Acute otitis media, not much has changed in this one. It's still children 1 to 17 years old. They've put the nice clinical knowledge summary link in. You've got your new gateway point for if it's, if there's acute complications or if they've got sepsis. The only thing that's changed in this is they have pulled out does the patient need an otoscopic examination from within the green box and merely highlighted it there. So it's pretty much saying if a child comes in with signs and symptoms of acute otitis media, you're going to look in their ears. And the moment you look in their ears, you've hit the gateway point. So as long as a child with ear pain comes into your pharmacy, for example, and you look in their ears, that's the gateway point. If then at that point you think, oh, look, they've got a bit of Lego in their ear, that's not otitis media, you still hit the gateway point. So it's fine. Impetigo, another one where the gateway point has moved further up in the pathway. So previously you would only hit the gateway point after you'd done your consultation with the patient and realised, well, actually, I think this is more likely to be impetigo than anything else. Then you hit the gateway point. Now the gateway point has moved up. So it would be anyone who comes in with symptoms of impetigo, do your red flag assessment, refer them obviously if they need to be referred. But then at that point, when you're sitting down to do a more detailed history, more close examination, do they have a history of eczema, that sort of thing? If then at that point you decide, well, actually it's not impetigo, it's infected eczema, for example, you've already hit the gateway point, whereas previously you wouldn't hit the gateway point. So again, more patients that you will capture. Infected insect bites. A couple of changes in this one. So the link to NICE, the new gateway point for an urgent referral. There's some information in here about Lyme disease, which apparently is increasing significantly in this country. So they've stuck Lyme disease right at the very top and sort of said, okay, consider the likelihood of Lyme disease right at the start of the process. And this is another one where the existing gateway point has now moved. And what does that mean in real terms? So that means that after your initial assessment and diagnosis, the patient may not require antibiotics and so can be given self-care and advice. And this is this pathway that goes across to the blue box, the orange box with the red circle on it. Previously, if you assessed someone, thought, oh, it's potentially an infected insect bite, we've got a few symptoms of it, but I don't think it's bad enough. I'm not entirely sure. I don't think it's bad enough to give antibiotics. I'm going to give self-care, monitor it, draw around it with a pen, get the patient to come back to me in a couple of days if it's spreading. Previously, if you did that, that wouldn't have hit the gateway point. And if the patient came back, great, with an infection, then you do it. But if the patient went away and actually the symptoms resided, the infection cleared up, or turned out it wasn't an infection, you wouldn't have been able to claim anything. Now, if you think that it's potentially an infected insect bite, you've hit a gateway point, whether or not you supply them with antibiotics or give them self-care advice and tell them to monitor it and come back. There's also the opportunity to claim twice for this one in a similar way that you can for sore throat. So because if you do refer someone and tell them to come back to see you, you hit the gateway point when you do your first consultation, but then if they come back to see you for another assessment, you hit the gateway point again. So you can claim twice for infected insect bites where you've told them to go away and come back to you if symptoms worsen, for example. And the last one is your UTI one. And again, nothing similar to otitis media, nothing has changed in this pathway. This seemed to be working quite well. Still no claim for pyelonephritis, unfortunately, which seem to be the majority of the patients that I see have pyelonephritis symptoms anyway. The gateway point for red flag sepsis, that's new, the link to NICE-CKS. The gateway point is still in the same place as it was. So actually, as long as you've ruled out everything else, if they've got, you know, if they've got one symptom, no symptoms, etc., as long as you've ruled out everything else, you've hit the gateway point for that one. The only thing that is changed in this pathway is that the NHS have highlighted do not have diabetes in the actual title of it. The PGD excluded people who had diabetes anyway, so it's no change practically, but they've just added it in the title here to be going on with. Any questions about the clinical pathways there? If not, I'll crack on. Fantastic, just shout if there are. So the PGD changes, so this is the legal documentation. So quickly going through the changes here. And again, these are summarised on the PGDs. There is a change section, so if you just make sure that you review those. In the nitrofurantoin PGD, they've just amended the wording from females to a, you know, cisgender, non-binary, etc. a definition. In real terms, no practical change probably for us in Gloucestershire, and removal of flu-like illness in the exclusions, simply because the feedback for that has been they've taken that out of the PGD because it was excluding some patients who didn't have any real symptoms of pyelonephritis, but when asked said, oh yeah, I feel a bit fluey, but it was quite obviously not pyelonephritis, it was just a UTI. So they've taken that out of the PGD exclusions. In both of the shingles PGDs, the acyclovir and valacyclovir, head and neck are now excluded. It was a bit vague before, sort of said trunk, and there was some confusion as to where the trunk stops and the head and neck begins. So now it's head and neck are excluded from both. They've taken out the allowance that you can give valacyclovir if acyclovir is out of stock. So you do have to hit the valacyclovir criteria, which from memory is that you can only give valacyclovir if they can't take acyclovir for some reason, due to not being able to remember to take 5 doses a day, that sort of thing. And they've added in 1 gram valacyclovir tablets into the PGD. Insect bites is an interesting one. They have now included definition of insect. Those of you who remember A-level biology will know that spiders are not insects. This really bugs me for some reason. But as per NICE and NICE-CKS, the term insect includes proper insects, so insects with 6 legs, and it also includes animals with 8 legs. I will not call them insects because they're not in the correct group. Anyway, so you can now treat spider bites, mite bites, and tick bites as infected. Oh, AL has. Oh, is that Andrew? You've got your hand up, Andrew.
It's Becky. Hi,
yes.
all. Yeah, so I do quite a few insect bites, as probably many people have done over the last few months. And they come in, 9 out of 10 times, they don't know what's bitten them. They've been bitten. So, yeah. And I know, I'm sure it wasn't a pun when you say it bugs you, but it does, because they will come in and they won't know what's bitten them. You're treating something. So I wouldn't be put off by what they think the definition of the insect is. It's a bite. And you're going to treat it if you believe it ticks all the boxes on the PGD.
Yes. Yeah. I'm just annoyed that they've lumped spiders in with insects. My A-level biology nerves are going. Ugh. Anyway. Yeah. Okay. And so they've also changed the exclusion criteria to be a bit more sensible around bites that occur outside of the UK. So previously it said bite or sting that occurred while travelling outside the UK, which would have excluded mosquitoes in France, for example, which there's no reason to refer someone with a mosquito bite in Normandy from the service. So they've changed the wording for this for bite or sting that occurred with a concern of an insect-borne disease. So if they've been to Borneo, for example, you might have a bit more concern than if they've been to Spain. So you can do outside of the UK now. Sinusitis, they've just made a minor amendment to the wording in there, but it does make a big difference to when you can supply. So previously the wording said 10 days or more, and it now says more than 10 days. So you can only supply sinusitis medication from day 11 now, not on day 10 legally. Although you could presumably just tell them to come back in the morning and you can do it if it's on day 10. That's neither here nor there. And there was an error in the original PGD because the nasal sprays, the steroid nasal sprays, had a requirement that you had to have 2 or more symptoms, which suggests bacterial sinusitis to give a nasal spray PGD. And actually, the vast majority of your sinusitis that are longer term are more likely to be viral than bacterial. So they've taken out that bacterial thing from the steroid nasal sprays, which is good. In all of the clarithromycin and erythromycin PGDs, they've added more medications in the drug interactions section. So there's a lot more things that you can't give them with. And they've taken the erythromycin high strength suspension out because it's no longer available. Again, nothing major in here. This is all things that we're probably doing anyway. The target information has been updated. So they have actually changed the requirement for the target leaflets. Previously, it was the generic target leaflet that GPs use. Now they have specifically said that we have to give these target leaflets, which are the ones that are for community pharmacy. So on both of these, you'll see it says for community pharmacy. So these are the ones now that you need to save to your desktop, print out, put in your folders, etc. And they're very slightly different. They're green and red for a start, which won't make a difference to us because we all print in black and white. But anyway, these are the ones that you're supposed to give to your patients now. So that's the changes to the pathways and the PGDs. The PGDs and pathways are on the NHS website now in draft form. So you can go and look at them, download them, print them, etc. But the actual documents, so the actual legal documents, won't be updated until overnight on the 30th of September. NHS England have put out one of the actual documents for superintendents so that they can get ready for the change. So I'm not entirely sure how to access that. It's probably on the website, but I'll have a check and let you know that, because that came out today or yesterday. But if you're an independent, I mean, if you're a multiple, your superintendent will be sending all these down to you anyway overnight on the 30th of September. If you're an independent, you'll have to get up early on the 1st of October and print off the new legal documents, because there is no overlap period. You literally have to stop using these pathways and PGDs at the end of the 30th, and on the beginning of the morning of the 1st, you start using the new ones. You can't use the new ones before the 1st of October. You can't use the old ones after the 30th of September. So that's just what you have to do, and that's a legal requirement. You may also need to update your Pharmacy First SOP, although a lot of the SOPs that I've seen don't go into a specific detail around the pathways and the PGD, so you might not have to, but do check it. And any other paperwork that you use, for example, your target leaflets, or anything else that has the gateway points on it for your staff, you might have to update those in advance of the 1st of October as well. Record keeping, what do you do with everything you've already done? You've already done your patient records, which are probably electronic. They will get archived indefinitely, but if you are changing IT systems, make sure that you get a copy of your patient records from your outgoing provider and you keep those. You do have to keep anything related to PGDs for 8 years for any adult PGDs and 25 years for any child-related PGDs. So it's quite a long time that you have to keep paperwork for. You do need a copy of the authorised PGD with signatures and a copy of any staff authorisation records if that's separate to the PGD document. So some people do have the PGD and the staff authorised, and a list of pharmacists authorised to do it. Sam?
There's a question in the chat.
Oh, hang on, I haven't got the chat up. Can you read it, please?
Otitis Media saw a 1-year-old today. No way was he going to stop shaking his head while I looked in his ear. Clinical history strongly suggested Otitis Media. Where do we stand in this circumstance?
If you haven't done the otoscope exam, you technically haven't passed the gateway criteria, and you also haven't met the PGD criteria. So if you cannot do an otoscope exam, you cannot legally supply the medication and you cannot claim the gateway, unfortunately. in that situation. I mean, there's tips to, try and sit the child sideways on the parent's head, get them to lean their head against the parent and the parent to hold the head steady. Sometimes it's just not possible and you end up having to refer them elsewhere. I mean, if you're an independent prescriber, you could make a clinical judgment without checking the eardrum, without checking in the ear canal. Again, that would be up to you as an independent prescriber, but under the Pharmacy First service, if you haven't looked in the ear, you can't do anything, unfortunately. Sorry. Just carrying on with this. So yes, all this has to be kept for otitis media for children. You have to keep this for 25 years. You don't have to keep it in paper form though, so you can actually scan all of these documents and archive it electronically and then just shred the originals. That's perfectly acceptable. You do have to keep them. The caveat to all of this is the IT system suppliers, same as usual. The system suppliers are planning to update their systems overnight on the 30th of September. So hopefully when you switch on Farm Outcomes or whatever on the 1st of October, you've got the new templates, etc. If the system suppliers are not ready, then the service change may be delayed because they have to be assured that the information that is going back to GPs that is now going straight into the GP clinical record, into the patient clinical record via GP Connect, they have to be assured that that's working 100% and the right information is getting there. So if the IT system suppliers aren't ready, this might get pushed. But we've heard that they are on track at the moment, and so we're still planning for a 1st of October change. So the last change is around the remuneration structure. So obviously back in June, the payments changed so that pharmacies needed to be registered to provide contraception service and hypertension case finding in order to get the additional monthly payment. So the fees, which are £17 for a clinical pathway or minor illness and £15 for urgent supply, that stays the same, but this is the monthly fixed payment for clinical pathways we're talking about here. So from the 1st of October, in addition to doing your clinical pathways consultations, you also have to do at least one ABPM per month in order to get that additional monthly top-up payment. And from March next year, you will have to do a as now unspecified number of contraception consultations, but we're still waiting to see what that looks like coming out. So we won't talk any more about the March change yet. The one that's important is the upcoming October change. So back in June, the monthly fixed payment changed to 2 bandings. So if you provide 30 or more clinical pathways consultations in a month, you get £1,000. Anything from 20 to 29, you get 500. It's only the clinical pathways consultation, so no minor illness or urgent supply, and you have to claim it within a month of the service being provided. So you can't do what we used to do with NMS and fudge it and push one over to the next month. If you've done it on the 30th of June, you have to claim it within a month of it being done. So you have to claim it in June, otherwise you've lost it, because when you claim at the end of July, it'll be outside of a month. What does that look like in real terms? So the ICB have done a bit of number crunching, which is fantastic. This graph on the left-hand side shows the payments that pharmacies have been getting according to the June rules when they changed. So the light blue band is pharmacies that got £1,000 and the dark blue band is pharmacies that got £500. So if we look at the June column here on the right, we see 42 pharmacies got £1,000 and 21 got 500. So that's 63 pharmacies in total achieved some monthly payment. If we apply the October rules, which is you have to do at least one ABPM, that number drops from 63 down to 20. So 16 pharmacies would have got the £1,000 and 4 pharmacies would have got 500. So 43 pharmacies not doing an ABPM, so wouldn't get that monthly top up. So it's quite a significant difference. We don't know which pharmacies, because we haven't got access to that level of data, unfortunately. We don't know which pharmacies are struggling to do the ABPMs, but we do sort of know roughly by locality. And we can see there's a huge difference here. So from Gloucester City in the top, where 21 out of 28 pharmacies will have achieved the new banding criteria, down to, Stroud and Berkeley Vale, only 3 pharmacies will achieve the new criteria. So it's massively You know, there's a very significant difference here, and the potential for pharmacies to lose quite a bit of money if we're not doing ABPMs. Something that also probably hasn't hit many pharmacies' radar is the caps, is that the Pharmacy First service is capped. And this is actually a cap on activity, and it's rather than to do with the monthly bundling payment, the monthly bulk payment, £1,000, £500. This is actually payment for consultations, for clinical pathways consultations. And if you go above, Sam?
Sorry, another chat. Do we know why they have implemented these changes at the same time that flu and COVID has started? Workload could have been spread better.
It could have been. It's NHS England for you. They were probably, I'd say, pushing to get it through before the winter starts, you know, before autumn, winter. They can't do it over the summer because there's too many people on holiday to do it. So it just happens to land in autumn. Sorry, we don't have any say in that, unfortunately. So the caps, so if you go above your monthly cap, you won't receive your activity payment. So forget the monthly £1,000, £500 fee. This is the £17 per consultation for pathways that you won't get. And the bands are actually quite low. So if you're a band 1 pharmacy, you can only do 32 consultations per month, and if you do more than 32 you won't get paid for 33, 34, 35. So it is quite important that you know which band you're in, and that you keep an eye on your consultations. Your banding is worked out based on 3 months average consultations from what you did 3 months ago. So not ideal. And obviously if you have, you know, if you're working hard on this and get great engagement with your local GP, you know, you have a change of ownership, a change of pharmacist, there's a local outbreak of impetigo, something like that. You happen to go to a nursery and mention that, you know, you do otitis media, or, you know, a class in school comes down with sore throat. There's a real danger there that will push you over the monthly cap and that you won't get paid for your service. So there's nothing you can do about it. We can complain to NHS England if it does happen, and we'd like you to let us know if that happens, if you go above your cap so you don't get paid, so that we can feed it back. And if you've gone over your cap and you know you don't have capacity to deliver these services for free for the NHS, then you don't have to provide a service that you're not being paid for. So you can turn around and say to patients, I'm sorry, I haven't got capacity to deal with you at the moment, but you do have to make sure that patient is seen. So you have to refer them on to another pharmacy, refer them back to their GP, and make sure that the patients are managed in a clinically appropriate manner. At the moment, we haven't had anyone that I'm aware of go over their cap, but I'm pretty sure we probably will, as we are still pushing, you know, to try and get GPs to refer more, and to try and get patients into pharmacies more. Sam, sorry.
Will caps be reviewed periodically so that your banding may change to reflect the work we are doing?
Yes. Yeah. So the NHS take an average of it's an average of 3 months for you. So this here is the table on this slide is September data, and they've looked at the average of April, May and June, and will put you in a band. And this banding number changes as well. So band 1 in September is 32, but band 1 in August was 30, I think it was. And it will depend. So obviously, if you've got a nice gradual increase in your Pharmacy First service, then you'll gradually go up the bands as your average changes. And so you will move naturally up the banding. But once you hit band 6, I think band 6, yeah, this month is 129. Anyone who does more than 129 Pharmacy First clinical pathways consultations in September won't get paid for the 130th consultation. So as an incentive to do them, but not an incentive to go mad and do loads, or to change your profile really quickly. So it's just highlighting that. So before we go on to the next bit, which we're running a bit behind, never mind. checklist for Is Your Pharmacy Ready? So go away, review the new clinical pathways and SOPs. We have been through them here. They're not as daunting as it seems, but make sure you've got them to look at there. Look at your Pharmacy First SOP and see if it needs updating. Brief your staff on the changes. Your staff are the biggest resource that you can do to drive this service. So make sure your staff know what they're doing. Print off your new clinical pathways or bookmark them, ready to replace on the 1st of October. And importantly, ensure that your hypertension case finding service is operational and that all staff know how to use the ambulatory blood pressure monitor and how to engage patients. I would go so far as to make sure that your ambulatory blood pressure monitor is working still. Make sure the software is working, still installed. If you plug it into the computer, does it actually work? Have you got batteries? That sort of thing. And get your staff to practice setting up that ambulatory blood pressure monitor, linking it through to the computer, taking it off again, that sort of thing. Andrew.
Yeah, just note of experience. The batteries run out quite quickly, so just be aware that you might get sort of really frustrated with the software, but just double check the batteries, because my experience, if they've gone out twice with a monitor, the batteries are dead after 2 people. So that's one of the big challenges. You just need to keep checking the batteries.
Thank you, Andrew. And then on the 1st of October, print, sign your new PGDs and replace all your paperwork and archive the old copies. Okay. Any questions before we go on to the what can you do to increase your income for this service bit? No, brilliant. Okay, I'm going to start with a little bit of feedback. So Sam more often than I do does get feedback from the ICB and general practices for moaning about pharmacies. So we're just going to highlight a few of these bits that do get fed back to us regularly. The first moan that we get is patients not being referred back in an appropriate manner. So if you can't treat the patient, or if the patient needs to be escalated, referred onwards somewhere else, you do need to make sure that that patient gets to where they need to go. We're not supposed to tell them to phone their own GP. We're not supposed to tell them phone back NHS 111. What you have to do is you have to do that referral for the patient. So option A for referring back is referring to the patient's own GP, and what you need to do is use the non-public number on an NHS Service Finder to phone the GPs, as well as sending them the electronic referral from Farm Outcomes or whatever system you're using. Phone the GPs and tell them that you're referring this patient to them or referring the patient back to them. If you don't know how to use the NHS Service Finder, just type NHS Service Finder into Google and it will bring this up. Select the Health and Social Care Staff sign-in. If you haven't got a sign-in, you just need to register using your NHS Mail. If you haven't got an NHS Mail, look on the LPC website and get an NHS Mail, because it's really quite important that you do have one. But if you log into Service Finder, go through the Health and Social Care Staff, search for a service in the same way that you used to do on NHS Choices on the NHS website, and it will bring you up the surgery details by postcode, by what have you. And on this, you will find a public and a non-public phone number. The non-public phone number, what was previously known as the backdoor number, is the number that you should be phoning and you are allowed to phone. If you get any reception staff or anyone else saying, why are you phoning this number? You shouldn't be phoning this number. Yes, we should be. Because we are healthcare professionals referring a patient in, and we are not going to sit in a queue for 20 minutes waiting for someone to answer the phone. We're using the non-public number, which should be answered straight away, because our time is valuable as well. Option B is to call back NHS 111. And again, when you are calling NHS 111, don't tell the patient to call back, because they'll just go back in a queue and probably end up being referred back to a pharmacy again. You need to call the NHS 111 healthcare professionals line for access to a clinician. So this is how you would refer someone to out of hours on a weekend. If you've had a referral through NHS 111 and you need it to go back to a clinician, again, phone 111 and go through the healthcare professional line option. And option C is to signpost to A&E or 999. If you do have to signpost to A&E, it's really good practice to telephone them first so that they're expecting your patient. Otherwise, there is a danger that your patient will get there and just sit in a waiting room for a couple of hours. They still might sit in a waiting room for a couple of hours, but if you speak to someone at A&E and tell them what your concerns are and why you're referring them, then quite often they will, when that patient gets to A&E, they've already got the information. Oh, actually, hang on, someone's already done a news assessment and thinks they might have sepsis. So we'll flag them straight through. So phone A&E first if you can, so they're expecting the patient. Missed referrals is the next one. So we quite often get patients walking in and asking for advice without saying that they've been referred, especially if you're not checking NHS Mail every half an hour. That happens quite frequently where we've got surgeries that are good at referring, the referral just gets missed. Quite often we get feedback from surgery saying, oh, you haven't contacted our patient. Well, hang on, we're not supposed to contact the patient is supposed to contact us. And I know some pharmacies do contact the patient. So again, it's up to you how you work the process in your own pharmacy, but the feedback is that a lot of the surgeries expect you to contact the patient. So it might be worth, if you have capacity, you contacting the patient to make sure you do get them. If the patient telephones rather than attending, there's a danger that you do a quick consultation on the phone, decide it doesn't meet the criteria, or it does meet the criteria, and you sort of end up, well, if it doesn't meet the criteria for a clinical pathway, for a gateway consultation, you can't claim for that patient because technically we're not supposed to do telephone consultations. You can do a video consultation and claim, or a face-to-face consultation and claim, but telephone consultations we can't really claim for. And if your patient is dealt with over the counter rather than by the pharmacist in the consultation room. So again, this is another one where we've missed an opportunity. I mean, if they've been referred and walked in and being dealt with OTC, then they might have been dealt with entirely appropriately, but we've missed claiming that patient because anything that's referred can be claimed. And the last bit of feedback from general practices is that the quality of our clinical consultations and record keeping is not, how should we put this, not always the best. Feedback is it's very evident which pharmacists are independent prescribers because their note taking and clinical record keeping is of a significantly higher standard than non-prescribers. So the important thing to remember is that a lot of the information from your pharmacy first consultation is added straight into the patient record nowadays via GP Connect. So someone at the surgery might not even look at it. It might just go into the patient record. And if then someone has to look at it a few months later, if it's a load of gibberish or rubbish or it hasn't got enough detail in there, then it's really difficult to follow up with that patient. So inconsistent or incomplete records, make sure you document everything. A lack of standardized approach, consider using a template, something like SBAR, to standardize your note taking in consultations. Prioritize. Don't prioritize dispensing over finishing a clinical record. If you've done a consultation, but the patient's gone already, but you've still got some notes to do, sit there and do them before walking back into the dispensary. You'll never go back to it if you've gone back into the dispensary and started checking again. And a lack of training and awareness. I've flagged up the CPPE clinical records training there. We should all have done that, but it might have been a little while ago. So make sure you know what should be recorded, which sorts of pieces of information are important, what's not important. And just review that if it was done quite a while ago. So what are pharmacists saying to us? We do still get some, there's no demand in my pharmacy, and I think we'll probably end up getting a few more of these when contraception service is really embedded. There's no demand in my pharmacy, but we would dispute that and say you're always going to have patients come in for sore throat, for example. I mean, otherwise, why have you got Strepsils on your shelf? So there is demand. We just have to recognise this. My GPs are not making referrals. That's a big one. And we are still working on this with the ICB. Sian and Kim are doing a lot of work with general practices. Sam goes out visiting general practices, has done training with reception teams. We can't force them to do it. We can just encourage them and keep chipping away at it. If your GPs aren't making referrals, you just have to step it up with the walk-ins, unfortunately, and try and capture all of those that you can. I'm doing lots of consultations that don't make the gateway criteria. Hopefully, That will be remedied a little bit with some of the gateway criteria shifting. I don't have time, I'm too busy. That's something that only you can fix in the pharmacy, and we'll go through some hints and tips for that now. So maximising efficiency is the first thing we're going to look at and discuss. And please, everyone, feel free to chip in if you disagree with some of these things, or if you can think of a better way of doing things. So the best thing you can do with your staff are your best resource. They're the ones that generally cost you the most amount of money, cause you the most amount of problems, but they are your biggest resource and they're your most valuable asset. A lot of staff are very highly trained and are not using their skills efficiently or effectively. So we try and get them working at the top of their license, and that includes pharmacists as well. So everyone should be working to the top of their license and using the skills that they've worked really hard for. So hypertension case finding service can be provided by any suitably trained and competent pharmacy staff member. The pharmacist doesn't need to be doing this. If you've got dispensers, dispensary assistants, dispensing technicians, even counter assistants that are competent and trained, they can do that service for you, just overseen by the pharmacist. Pharmacy First, still provided by the pharmacist. Technicians can't do that. But vaccination services now, all of your vaccination services can be done by a pharmacy technician or pharmacist. And if you're using the protocol for COVID or flu vaccination, then your pharmacy technician can run the whole thing for you with using your non-registered colleagues that are trained vaccinators to administer vaccines. Andrew.
Yeah, just briefly, it might be worth noting, Becky, there that some corporate groups of pharmacies might have their own rules about allowing pharmacy staff. So it's, whilst you can, some corporate pharmacy groups actually still don't allow that.
Yeah. Okay, very true. Don't know why, but that's fine. Use of checking technicians and accredited dispensary accuracy checkers for accuracy checking. I mean, we've been pushing accuracy checking for decades now. We still don't have many checking technicians or checking dispensers. Hopefully that will change going forwards. There is free ACT training through CPP at the moment. So if you've got any pharmacy technicians that don't have a checking qualification, go onto the CPP website and sign up for the free checking training. It doesn't cost you anything. Get that technician checking. Hub and spoke dispensing models will be legal soon. Well, legal already within a company, but they will be able to be used between companies, which is an opportunity for some. Review your staff scheduling. Have you got the right people in at the right times? Quite a lot of pharmacies are still operating on a staff schedule that assumes you go out in the morning and pick up prescriptions from pick up a bundle of prescriptions from your GP's paper from your GP surgery and dispense those, then go out at lunchtime again and pick up another bundle of paper. That's not necessary anymore with EPS. And staff training. Do people know what they're supposed to be doing? So your team is your biggest asset, and they're probably the one that we underutilize the most. Drive demand for your services. So how can we engage patients and raise awareness of Pharmacy First? So I see Matt's on the call, or he was earlier on. I hope he's still there. You have a fantastic resource with some ICB funded primary care network pharmacists that are throughout the county. Every county has a PCN pharmacist or pharmacy technician whose role is to go out once a month and try and engage with pharmacies and build relationships with GPs and help to sort out any problems that are, that might be brewing there all around these services, and try and get GPs referring patients in. So please do engage with your PCN lead pharmacist. If you don't know who it is, please let us know and we will make sure that PCN pharmacist contacts you. Engage with your GP surgeries. Are your surgeries referring? If not, why not? What are the barriers to them? Feed that back to us, feed it back to the ICB, and we'll go in and help them overcome those barriers. Are they referring the right patients? This is something we get fed back quite a lot from pharmacists, is that, oh, my GPs are referring, but they're not the right patients. They're not minor ailments patients. A lot of the times when you're getting referrals from GP surgeries, or even from NHS 111. It's not a clinician that's referred that patient to you. It's a care navigator. It's someone who's sat at a computer, answering a phone, following a pathway. And you have to bear in mind that you are the first clinician that that patient speaks to. So quite often you get patients referred with toe pain, and it might turn out that they've got a broken toe. That's not really a minor ailment, but you can still, if it's been referred to you, you can claim it as a minor ailment, even though you might have sent them to A&E or to minor illness or whatever. Because you do have to bear in mind, there's, you know, the people referring to you aren't clinicians. They're people who are just responding to a patient telling them they've got a symptom, and they're making their judgment, or they're following their computer that says send them to a pharmacist for assessment. Is the DOS correct? So the DOS is the Directory of Services, is the tool that NHS 111 and NHS 111 online will use to refer patients to you. If your opening hours are not correct, if your services are not correct, if your postcode is not correct on the DOS, then you risk not having patients referred to you. And we have had some situations, I mean, Sam chases regularly where people have dropped off the DOS for some reason, or a service hasn't been added, or something to do with their IT provider hasn't enabled something, which means they've dropped off the DOS. And if you drop it off the DOS, you won't get any referrals. So make sure it's correct. Can your staff convert walk-in patients to clinical pathways consultations? This is a really big one. It's something that the supermarkets seem to be doing really well. Anyone that walks into your pharmacy with any of these 7 conditions, you know, you'd need to make sure that your counter assistants, that your dispensers who are serving on the counter are asking the right questions to assess whether, you know, they can be diverted into a clinical pathways consultation. And if you've got new staff or staff that aren't aware of the criteria of the service and the gateway points, it might well be that you just, you know, that these new staff, if someone walks in with a sore throat, I want you to refer it to the pharmacist straight away before you even ask them any questions. Because sore throat, 9 times out of 10, that's going to meet the clinical pathway gateway for a fever pain score of 2, which, you know, will give you that £17 and that extra bump towards the £1,000 bonus at the end of the month. Availability and willingness of pharmacist, especially difficult if you run on locums, but don't give the locum an option. You know, I've got a patient for you, they're in the consultation room. It's really hard for a locum pharmacist to turn that patient away if you've already got them in the consultation room. So telling your staff to, if they identify a patient, sit them down in the consultation room and then go and get the pharmacist is a good way to make sure that pharmacist does the service. Some pharmacists are great at social media, some aren't. Personally, I don't use social media. It's something I'm very poor at. I know I need to get better at it, but some pharmacies are fantastic at social media, and there's a couple of screenshots there from, I've stolen the one from Day Lewis for their flu advertising, where they've done a reel for, you know, promoting flu to pregnant people, pregnant women. And there's a post here from Wellbeing Pharmacy. That's a Facebook post, just sort of, that takes 2 minutes. You know, did you know you can get any of these symptoms treated in your pharmacy? Come and see us. And even if you get 1 share, 2 likes, whatever, it's a couple of extra people that have seen that, and it might be passed on to someone, you know, and they might think back on it. Oh, yes, I remember where I can get that now. And then engaging with local schools and businesses. There's a really big untapped resource in nurseries, I think. So talking to local nurseries about whether you can put a poster up or whether you can put your pharmacy details out, you know, whether they'll let you give a leaflet, send a leaflet home with all the kids about, actually, you know, has your child got earache? Don't go to the pharmacy, walk in, you know, don't go to the GP surgery, walk into the pharmacy. We can look in their ear, check, give you advice, possibly antibiotics if needed. Children are always getting ear infections, especially in nurseries, and if one gets it, obviously someone else will as well. Sore throats, children always get sore throats. Impetigo, that will go around a nursery and like that. So if one parent knows about it, they'll tell other parents. So engaging with local schools, businesses, nurseries, that sort of thing. Missed income opportunities. So if you don't set targets for your staff, you should. Set targets that are specific, measurable, achievable, realistic, and timed. So set small daily targets rather than large monthly targets. Don't tell, look at your cap and say, right, we've got to hit 30 this month. Don't tell your counter staff that. Tell them, actually, we've got to hit 5 this week, or I'd like you to do refer one person today. So smaller targets are a lot easier to achieve than monthly targets. And if your staff are hitting their targets, give them praise. You don't have to give them a financial incentive, although I know that some companies do. You don't have to give a prize. Just telling someone, oh, that's fantastic, you've done a really good job, will actually boost morale significantly. So give them praise if they've hit the targets or done what you've asked of them, and focus on one area at a time and do it very well. We've got 7 clinical pathways. Focus on sore throat. It's a really good one to focus on. The LPC has put together some information to help with your PQS completion at the moment, the pharmacy quality scheme. One of the items in PQS is the sore throat audit. So we've got some audit paperwork. Sam's going to upload it up to the LPC website, and we're going to send out some information about it early next week. But focus on sore throat. You can combine the sore throat audit with, target every single patient that walks in with a sore throat, and focus on one area and do it well. Get that really embedded. Use something like a little tick box chart that, that your counter staff or your, or even your patients can, and if they tick more than 2 of those, then they get referred straight to the pharmacist. So little tips like that. Do daily staff huddles. I know it's difficult when your staff will come in at different times, but actually if staff know what their tasks and targets are for the day, then it's a lot easier for you. It's a lot easier for them if they know what they're doing. And especially when you combine that with regular feedback, it really gives you more motivated staff that support you to get these targets under the belt. Complete records on time, we've already talked about. Don't put it in a drawer and forget about it. We won't mention the Boots pharmacy that put all their stop smoking vouchers in a drawer and forgot about them. Don't do that. Convert high blood pressure results into ABPM. Really important one for the upcoming months. A lot of people are doing the blood pressure clinic checks, and a lot of the blood pressure high results are going straight to the GPs, and the GPs are starting to notice, hang on, why am I getting this BP referred to me for me to see the patient and give them a home monitor or something like that? The pharmacy should be doing these ABPMs. And what the LPC and the ICB are trying to give sort of some concise messaging that actually we want GPs to be telling patients to go back to the pharmacy for this. So actually, we want GPs to be pushing into the ABPM service. So we want, actually, if a healthcare assistant in the surgery picks up that a patient has high blood pressure, we want that pushed to pharmacy for ABPM, because ABPM is the gold standard for diagnosing hypertension. It's not the home monitoring, which we hope will go on to the hypertension case finding service in the near future, but we want patients doing the ambulatory blood pressure monitoring through pharmacy. Andrew?
Yeah, again, just briefly, and from experience, you get someone in who's 190 over 120. Clearly, it's high. You've got to convince them that they need the ABPM, because it is your clinical responsibility. If that person is referred to the doctor's surgery and they don't go, and they have a stroke that day or the day after, then the last clinician to have taken their blood pressure is you. So ultimately, you do have that clinical responsibility to convince the patient to have the ABPM fitted. And if they genuinely refuse, then you should record that and make sure it's a refusal on farm outcomes, because you're then covering yourself from a clinical negligence lawsuit if that patient then subsequently has a stroke or ends up in another part of the system. So I just qualify that. Yes, it's difficult, but these are monetary opportunities not to pass by. So thanks for highlighting that, Becky.
Emma?
Yeah, I think as well with ABPM, it's just your confidence as well. You can only sell something if you're confident in doing it. I observed a locum last week who had somebody with high blood pressure and went to pieces because they couldn't really understand what ABPM was. They didn't know how to fit it. So then the patient just walked out the pharmacy. So I think you've just got to have that confidence as well. So practice, do some chatting to another colleague, explaining how, mock up a situation of a high blood pressure and how would you sell ABPM to someone. I just put a link in the chat as well to a really useful leaflet. If you go through it with your patient, they really understand it and get it as to why it's so important.
Brilliant, thank you, Emma. We'll send that link out if that's okay with you. Another good tip for ABPM is to actually wear it yourself for a day, and then you can explain to your patient exactly what's going to happen. But yeah, as Andrew says, explaining to your patient why it's clinically important that they, that they get a correct diagnosis of hypertension and that these are the risks is really important as well. And again, this all links back to the NHS 10-year plan to try and increase the clinical skills of pharmacists, and we will end up doing obesity and hypertension in pharmacy. We will end up with it being with pharmacists prescribing for these conditions. So we have to get better at doing this. GPs can do it, we can do it. And as Andrew always says, if he can do it, anyone can do it. And offer services to patients at every opportunity. So you need to get your staff into the mindset of actually this patient doesn't walk out of the door until I've maximized every opportunity with them. So they've come in for Strepsils. Have I made sure that they don't, that they haven't got 2 on a fever pain score of 2 or more? Is it just a sore throat? Sore throat, no cough. How long have you had it for? Oh, brilliant. Let's double check that for you. And even if they do end up with the Strepsils, out of 10 they probably will, you've also got that £17. They've had that clinical consultation, you've hit a target, and you've got a patient that's walked out of that pharmacy thinking, God, I didn't know the pharmacist did that, and it's really useful. I've got a leaf, I've got a target leaflet, I know what red flags to look out for. I'm going to go back if this doesn't get better. And that's so much better than just selling them a packet of Strepsils off the shelf. Link services, so we do a lot of blood pressure checks with flu vaccinations. Not always the best time to do it, because if you do have someone with high blood pressure, you don't always have the time to convert that into an ABPM. But if it gets you going in the right direction, fantastic, do it. Maximizing throughput. So a big one that we have all these SOPs that we look at, and part of my job with Day Lewis is looking at SOPs and reviewing them. I would say nine pharmacists out of 10 read an SOP, sign it, and put it in a folder and forget about it. Your SOPs are there because they should be the best way of doing something. And if you were to really look at an SOP and say, do I do everything on this SOP? You probably wouldn't be doing that. So are your SOPs up to date, and are they followed? Sam?
Jared's just put something in the chat. ABPM, practice fitting it onto each other. Think about the practicalities as patients to wear a t-shirt to make it more comfortable.
Brilliant. Yes, thank you. Really good tip. This time of year it's very difficult. And when they come in for flu vaccines with 6 layers on them, yeah, very difficult. So make sure they're wearing the correct thing, and it's scheduled at a convenient time for both you and the patient. If you've ever done any management courses, you might have come across something called Lean. Lean is a process by which you can map your workflows and identify any areas where you've got bottlenecks in the pharmacy, or duplication, or non-essential steps. So it's really good to put this into ChatGPT actually and say, can you suggest me some Lean processes for reviewing my dispensing process? And the stuff you come out with is really quite effective, but you can use this Lean tool to identify where you can make your dispensing processes more efficient, and use task batching for repeat prescriptions and blister packs. Task batching is where you do one thing at a time. So if you are making 100 sandwiches, you don't take 2 pieces of bread out of a bag, put the butter on, come over to the next bit, put the ham on, chop it up, put it on a plate, you butter 100 slices of bread, you put the ham on 100 slices of bread, you chop up 100 things. So you do things in batches rather than all the way through. I see this a lot in pharmacies when I walk in, is you see a patient hand a prescription in at the counter, your counter assistant, who is probably dispensary as well and is bored on the counter, takes the prescription, goes into the dispensary, stands at a PMR, labels it, puts it in a basket, goes and picks it, labels it up again and puts it to be checked. Your counter assistant has just done a really inefficient job there. What they should be doing is just handing that prescription back and letting it go into the dispensary process. But instead, they've walked into the dispensary, they've left the counter, they've disrupted everything in the dispensary. They haven't used task batching. They've just, seen the process through. So looking at how you're working as well to make it more efficient, to maximise throughput. And this one again, we're really bad at. Focus on services that improve outcomes and generate income rather than services that don't generate any income. How much time did you spend today checking Dorset trays? How much time did you spend sorting out things for delivery to patients? Those are services that I would argue don't improve patient outcomes, as well as costing you money rather than generating income. So those are things that you should not be doing. They're things that I would argue pharmacy should not be doing either. And hub and spoke dispensing models to free up clinical capacity. I've got a video on the next screen. I would just like to caveat this by saying the LPC is not pushing any particular dispensing software or the dispensing process. These two videos that I'm going to show you now are just to showcase what you can do with innovative models of dispensing. So this one is about hub and spoke dispensing. Can you hear the music? Hopefully you can hear it.
No, not in a minute. No.
Ah, right. That's annoying. Hang on. Share sound. I forgot to press the button. Share sound. Right. Can you let me know if you can hear it now?
Yeah, that's it.
Thank you.
So since we've implemented sensor solutions in the pharmacy, we've seen a massive reduction in stress levels, efficiency, increase in efficiency. It just allows us to free up the time really of the skilled staff. But I think most pharmacists will resonate with this, is that we felt really under pressure to keep up with the admin side of it, the increased services and expectations of the NHS and the doctor's surgery. And I feel like it was time for us to get that support. And it's just allowed us to be able to give that great customer service that we always have done, but we found it harder and harder because of the increased volume. So we don't have to now worry about making sure that we're getting this huge volume out to the patients. All we need to worry about is, does that patient know how to use that medication? Do they need any extra advice? Do they need to provide a service to them? And that's the biggest selling point for me. I mean, it's a complete no-brainer for anyone that's doing high volume. I don't understand why they wouldn't do it. NHS services, we do everything you can think of. So CPCS, NMS, very high volume on the NMS. So we do most of the country actually most of the time. We do flu jabs, we do everything you can think of. But I think the biggest increase for us really has been the private services. So now we've moved into aesthetics, blood testing, hormone replacement, travel clinic, pretty much like a mini doctor's surgery now. And that's the ethos I'm going for. Is we're moving into that kind of health hub, rather than it being just a pharmacy that supplies medicines. I feel like we're at the forefront of that, and I'm pushing the boundaries more and more and more. We're even doing like kind of, my colleagues are doing like minor surgical procedures in the pharmacy. So, it's really different to what it was 5 years ago. Previously, we would have to signpost patients to different services, and they probably get lost in the system. Now we can do everything in the pharmacy. We don't lose them. We can then cross-sell, we retain their custom, and then obviously off the back of that we probably end up getting their prescriptions and the rest of their family. So it's a win-win. Our Sensor Solutions offering really was to support initially our AR pharmacy, Totton, because it was such high volume, and that's perhaps why people wouldn't or usually look at a Sensor Solution, a hub and spoke system for that reason. But it really massively helped us. And then off the back of that, it's allowed us to look at other opportunities to grow and expand. We never thought 5 years ago that we'd buy another pharmacy. We've already bought one, we're buying 2 more, and it doesn't scare me, it doesn't worry me, because I know the Centre Solutions is going to be able to support that volume.
There we go. So that was just a quick hearing from a pharmacist about hub and spoke dispensing. And I know a lot of multiples or have already started using hub and spoke. I mean, it was in its infancy 10 years ago, but a lot of multiples are using hub and spoke now. With the change in legislation coming up, independents, single sole traders will be able to use hub and spoke dispensing to free up pharmacist time, dispenser time going forward. So it is something, if you haven't looked at it already, please do look at it. And we're nearly at the end. Digital systems. So actually really promote online prescription ordering. We still have a lot of pharmacies that have a phone constantly ringing with patients phoning up to order prescriptions. We will always have a few, but we need to really push online ordering solutions. So the NHS app, individual pharmacy standalone apps, that sort of thing. It's a lot easier for patients to do it themselves. They don't have to hang on the phone. They can use the app. They can do it at 10 o'clock at night. They can see when their prescription's been generated by the surgery. With the development with the NHS app, they will soon be able to see when their prescription is ready at the pharmacy for collection. Using online booking systems and pre-consultation questionnaires, especially if you're offering private services as well as things like flu vaccinations or other vaccination services. Using an online booking platform that has built-in questionnaires can massively reduce the time that a patient is in your consultation room there, and using your PMR systems to free up staff time. I'm going to show you really quickly a video about Titan, which I thought was quite funny. Just to show the sort of thing that, and again, the LPC is not supporting the use of any particular PMR system. A lot of people won't have any control over that anyway, but independents, we're not promoting any particular PMR system. We're just saying it's worth looking at what digital systems you are using to see how your system can free up your time, what data you can get out of your PMR system to target patients. When we're looking at the pharmacy contraception service, you could run a report at the beginning of every month, find out which patients are on desogestrel, phone them. You've got then, you know, there's your patients for that month on your contraception service. There's lots of things that we can do using smarter stock management to reduce your dispenser workload. You know, fast moving lines. Why aren't we ordering these in bulk? You know, if you have the cash flow to do it, can you order order some of your amlodipine 50 at a time? Therefore, the dispenser puts it away in bulk rather than 3, then 4, then 7, then what have you. So it's a lot easier, things like that. So smarter stock management systems. I'm just going to show you this about Titan.
Meet Akbar.
I am the owner of Drayton Prime Pharmacy, and I'm a pharmacist as well.
Also Exeter Community Pharmacy, Mount Pleasant Pharmacy, Somerdale's Pharmacy, Gosport Community Pharmacy. And like he says,
so you've got to imagine we are a 32,000 item pharmacy per month. That's 4 times more than most pharmacies.
And yet,
day-to-day wise, I'm not involved at all. But the Titan's given me that time. It allows me to focus on strategic.
Not just the system. This only works because of people like Maliha.
So I wouldn't say I run it. I'm just, in the background, I guess, and making sure the work gets done. When things drop on Titan, it just automatically gets done. You're not waiting around so much.
Prior to Titan, we had ProScript Connect. So back in those days, we used to print off scripts, and then print off labels, and then check. It was just manic.
You don't have to have eyes towards the back of your head when you're using the system, whereas with ProScript you did, and because you've got an audit trail on Titan, so you know exactly who's doing what, when it was done.
We finish everything, so we clear everything. The owings on a Monday, there'll be 30. By the end of the week, you'll have 2 owings.
I'm not glued to the screen all the time. Titan AI is doing about 70% of the clinical checking, so my workload has reduced dramatically.
At the time we were getting Titan, we were either going to get a refit or get Titan. And I went with Titan, and I didn't need a refit because Titan saved me a lot of time. and effort and money. Before, we used to have a lot more staff members. I can comfortably say that we've saved probably about 3 or 4 staff members. Yeah, before Titan, you'd be there till 2 o'clock in the morning, and I had a staff member who turned around, looked at me and said, "This is hell." A month after we got Titan, they looked at me and said, "We can go home on time."
If I finish at 4:30, I'd go home at 4:30. And to be honest, I can log into Titan from home.
I would say to all my competitors in and around this area, don't get Titan. Stay paper-based.
I do believe the pharmacy runs much smoother since going onto Titan. It's more efficient, more reliable as well.
So obviously other PMR systems are available. And when I saw that video, I was very concerned about the 70% AI clinical checking. But reading a bit more about that, this is, it's things like you clinically check a patient's medication once, and if they've got the same repeat medication the next month and nothing has changed, the system will detect that nothing has changed and just pass it straight through. So it's not, it's still a clinically robust system, and it's things like these systems that we should be thinking about how we can use these more efficiently going forwards to free up our staff, who are still our most valuable resource and who always will be our most valuable resource. We're never going to be able to do this without staff. And so my last slide, action plan for the next month. What sort of things can you do? So your immediate quick wins are your staff engagement. If you have an engaged team who are identifying patients, who know what they're doing, who are targeting things, who are making sure your dispensary runs efficiently, this is an awful lot easier for you, and you will hit your targets. Implement tools to identify eligible patients, both for hypertension case finding service, making sure you're grabbing those patients when you see them, and so that when patients walk in, you're identifying this is a clinical pathways patient and getting them straight to the pharmacist. Introduce simple targets and KPIs. So look at what you want to achieve and set your staff a daily or weekly target. Reach out to your PCN lead pharmacist. Or if you've got a really good relationship with your local surgery, reach out to them to find out, what are your barriers? Why aren't you referring patients to me? Link services. With flu coming up, I know it's a really busy time of year, but if you're not doing blood pressure checking, it's a really good time to get blood pressure checking whilst you're doing flu vaccinations at the same time. Find your ABPM, make sure it has batteries, make sure the software works, make sure staff remember how to use it. Remember, from the 1st of October, you must get that ABPM one a month in order to get your monthly payment. It's a big whack of money you're losing if you're not doing that. And in the longer term, look at these strategies for how to make your pharmacy more efficient. So maximize throughput, look at your workflow challenges, look at your staff challenges, make sure you've got a staff training calendar in place. GPHC really like that when they're doing inspections, by the way. If you've got a good staff training calendar that identifies what your staff needs and helps them get there, and map your processes and look at where you can make things more efficient. Keep engaging with the PCN and the PCN leads. These are going to evolve into your neighbourhood teams, and we really need to be in at the ground floor to make sure we've got a seat at the table, make sure we're involved in things, and arrange regular surgery meetings if you haven't already done so. The key takeaways: ready for the 1st of October, make sure you and your staff are ready for these changes that are going ahead. Engage your patients and no missed opportunities, and longer term, look at your workflow systems and processes to build a pharmacy fit for service delivery in the future, not for dispensing, service delivery. Any questions? Sorry, we overran a little bit there. No? Fantastic. Okay.
And Becky Andrews, you say it, Andrew.
I just put something in the chat, and just to qualify, when you mentioned earlier on about the PGD requirement records being kept for 25 years, is that for a particular age group, was it?
Yes, if it's a child, you're delivering services to a child.
Yes.
You have to keep the records until they turn 18.
Okay.
Or for 8 years. So
Okay.
you need to keep them for 25 years to cover your 1-year-old and then 18 and then 8 or whatever. So yeah.
Okay. So my guide would be, if you're thinking of buying a pharmacy in a company, then if you're buying that company from a existing pharmacy owner, you need to check on your checklist to make sure that the records are being transferred with that business, because it will be your responsibility.
Yep.
If somebody comes to you in 8 years' time, have you got the previous records? I'm just saying that's going to be quite key coming forward, isn't it?
Yeah.
Okay. Lovely. Thanks for clarifying that. No, a great evening, Becky. Thanks to you and Sam and the team for putting it on. It's really informative. I hope everyone's, got the benefit from all of this. It's been brilliant.
But yeah, if you do have any questions or feedback, please feel free to drop us an email. Sam's going to put this checklist on the website. I emailed it to you about an hour ago, Sam, sorry. Well, hour and a half ago now. And we've got some PQS stuff that we're going to share with you all as well to help you hit your PQS.
Just a quick question, obviously, is this something that you think the LPC should be doing more of? You find it informative? Be great to have your feedback via email or WhatsApp, whatever. Be brilliant. Thanks, Becky.
Lovely. Thank you. And sorry for going over, and also sorry if you came on Friday and when my computer packed up halfway through. Okay, cheers. Bye.
Take care. Bye.